Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Welcome back to part 2 of our conversation. Please be sure to listen to part 1 of this episode. Now, let's go back beyond the pages. Dr. Lee, let's move on now to glucocorticoid withdrawal syndrome. When should an internal medicine doc think about the syndrome? What are some key signs and symptoms? And importantly, how do you test for it?
The key message here is history. The medical history, surgical history, and the medication history. Unlike glucocorticoid-induced adrenal insufficiency, glucocorticoid withdrawal syndrome can be caused not only by taking exogenous glucocorticoid, but also can be caused by endogenous cortisol overproduction, in other words, Cushing syndrome. After a curative surgery for Cushing syndrome, this patient may develop glucocorticoid withdrawal syndrome. I think as an internal medicine doctor, we should consider the glucocorticoid withdrawal syndrome in those patients who have taken high-dose, long-term glucocorticoid treatment for other underlying inflammatory conditions, as well as they have a clear history of Cushing syndrome who underwent a successful curative surgery for Cushing syndrome. I'm not sure if there are any key signs and symptoms for GWS. The reason is that GWS often has very non-specific nature in its symptomatology. These include, but are not limited to, fatigue, weakness, joint and muscle pain, which can often actually overlap with their underlying inflammatory condition, which they took steroid for. Fever, headaches, nausea, vomiting, low appetite, weight loss, etc. Another important note is that these symptoms may occur anytime during tapering of exogenous steroid, not only after stopping the steroid completely, but also sometimes when they remain on high dose or supraphysiological dose of steroid. In terms of the test, again, there is no laboratory test to diagnose GWS, which is a clinical diagnosis. In other words, their baseline cortisol does not need to be low to have GWS. For example, we could have somebody in the clinic who has already stopped using steroid, who has demonstrated normal baseline adrenal function. However, the body could still have long-lasting and lingering physical and psychological dependence on the previous steroid exposure, and therefore, they could still experience GWS. I hope I answered your question.
Yes, you did. So how is glucocorticoid withdrawal syndrome different from GIAI?
Sure. As what has been mentioned by Dr. Lanza and Dr. Nachawi, these two entities have some similarity in symptomatology. However, they are distinct conditions from many other aspects. First of all, from the etiology and the pathophysiology standpoint, GRAI results from prolonged glucocorticoid exposure leading to suppressed signal from the hypothalamus and the pituitary gland, causing atrophied adrenal cortex over time, and the adrenal gland cannot make sufficient cortisol. In contrast, GWS occurs when the body develops physical and psychological tolerance and dependence on supraphysiological dose of glucocorticoid. Their adrenal gland could be intact. Secondly, GRAI can be diagnosed and confirmed biochemically, whereas GWS, as mentioned earlier, is a pure clinical diagnosis that heavily relies on their clinical history, symptoms, and signs. There is no laboratory test to rule it out or to confirm it. Last but not least, from the prevention and treatment perspective, GRAI can be treated with standard glucocorticoid replacement therapy, usually at a physiological replacement dose. Adrenal action plan should be in place while on the replacement to prevent adrenal crisis during acute illness or stress. On the other hand, for GWS, we often try to compensate for the symptoms from GWS with the lowest effective supraphysiological glucocorticoid dose. In terms of how low is low and what is the effective dose, every patient varies and there is no one size for all. It is often empirical by the treating clinician, and sometimes we have to increase the glucocorticoid doses when patients report some worsening of their GWS symptoms, although we try not to, as it could further prolong the recovery process. So these are the main difference between these two diseases, and I encourage everyone to refer to the table in the manuscript we published.
What is the recommendation regarding the assessment of the recovery of the hypothalamic pituitary adrenal axis in GIAI?
Yeah, I'm happy to take that question. So I have to mention that by the time we wrote this review article, there were really no national or international consensus on how to treat GIAI or taper glucocorticoid, or how to assess the recovery of the HPA axis. So in the review article, the recommendations we have are based on our expert opinion, and also based on the expert opinion that we have in the literature. So to go over this, first, I would like to go over how to actually taper the glucocorticoids in an efficient way. So to taper glucocorticoid, we recommend a quick glucocorticoid taper when patients receive high doses of glucocorticoid, and then the taper will have to be adjusted and slowed down as the dose of the glucocorticoid is reduced, and approach a physiologic dose. So for example, if the patient is treated with high doses of glucocorticoids that are higher than 40 milligrams of total daily dose of prednisone, the taper starts by cutting down by 10 milligrams weekly until the patient reaches a dose of 40 milligrams. And then after that, the taper is slowed down by cutting 5 milligrams every week until the patient reaches a dose of 20 milligrams total daily dose of prednisone. After that, the taper is slowed down further by cutting 1 to 2.5 milligrams weekly until the dose of glucocorticoid reaches 10 milligrams or less. And at that point, we slow the taper even further by cutting back only 1 milligram on weekly basis until the patient is on total daily dose of 5 milligrams or less of prednisone. At that point, it's actually recommended that the prednisone, when it's closer to the physiologic dose, we recommend that we switch the prednisone to hydrocortisone. And we do that to make sure that the patient is exposed to the glucocorticoids for a shorter period of time. So hydrocortisone has a shorter duration of action. And that should help with the restoration of normal function of the HPA axis and also restoring the circadian rhythm. So when the patient is on prednisone dose of less than 5 milligrams, we recommend switching over to hydrocortisone, 10 milligrams at 8 a.m., and then 5 milligrams at 2 p.m. And then at that point, I think it would be a good time to start checking the function of the HPA axis. And that is actually done by checking 8 a.m. cortisol. And we recommend checking 8 a.m. cortisol in these patients after holding the evening dose of hydrocortisone for at least 24 hours. So what I usually tell patients is that take your morning dose of hydrocortisone, skip your evening dose, your 2 p.m. dose of the 5 milligrams, and then come into the lab between 7 to 8 a.m. to get the cortisol checked. And depending on the cortisol level, that's when we kind of decide what would be the next step. And before I go over the numbers, I want to highlight that the numbers in our review article are based on the newer cortisol assay that is available at the Cleveland Clinic. But other assays at different institutions go by different cutoffs. So the listener and the reader should be able to kind of refer to the reference range at their institution and the assays that are used. So when the 8 a.m. cortisol level is actually less than 10, then we consider that the HPA axis has not recovered. And in that scenario, we continue the hydrocortisone 10 a.m., 10 milligrams at 8 a.m. in the morning and 5 milligrams at 2 p.m. And then we recheck again after 4 to 8 weeks. If the 8 a.m. cortisol is above 10, that could be a sign of a recovery of the HPA axis and could reflect that the patient does have decent and normal cortisol secretion at baseline. But we want to confirm that these patients also do have enough adrenal reserve and they're able to produce more in situations of stress, whether it's a physical or emotional stress. And therefore, in these patients, it's recommended to pursue a cosintropin stimulation test. So when we do the stimulation test, we look at the peak cortisol. And if the peak cortisol is greater than 12.6 microgram per deciliter, we consider that the patient has enough reserve and they're able to function well and they have enough cortisol in situations of stress. And if they're ready and they don't have any GWS symptoms, we can consider stopping the hydrocortisone altogether. If the peak cortisol did not go greater than 12.6 on the ACTH stimulation test, then after discussion with the patient, we can consider stopping the hydrocortisone daily doses, the 10 milligrams at 8 a.m. and the 5 milligrams at 2 p.m. But we can recommend actually using a stress dose only for physical or emotional stress, just to make sure that they're safe and they have enough in their system. After the publication of this review article, the guidelines of the Endocrine Society and the European Endocrine Society actually were released in May of 24. Actually, the guidelines are in line with our recommendations. So they recommend a very similar taper and the testing. The cortisol levels that are highlighted in the guidelines also depends on the assays that are available in different institutions. So again, I would like to stress the audience and the listeners to always check the reference range where the labs were done. I think I want to highlight a couple of the differences. So the Endocrine Society and the European Endocrine Society does not necessarily recommend switching prednisone to hydrocortisone. Similarly, they do not also recommend ACTH stimulation tests. They don't strongly recommend the ACTH stimulation test. So I think it's always when seeing these patients in whom we suspect GIAI and who also have some concerns or symptoms that could point into GWS, it is important to have these discussions with these patients, see what are their comfort level and what they're comfortable with, and then decide on pursuing these tests or not. And just like make a patient-centered decision in terms of their care.
Good. Well, I wanted to thank all three authors for taking the time to speak to us today about this important topic. But before we break, I wanted to give each of you an opportunity to outline what you feel are the key take-home points for our audience today.
I'll take the first one. I think it is important that clinicians realize that there are sources of exogenous glucocorticoids that are just not oral. And with good history taking, we'll get to the answer. Intra-articular and epidural injections should be asked about. Inhalers might seem that they're obvious, but unless they're specified, we won't know. And then again, the high-potency topical steroids, especially if applied to areas with thin skin or with occlusive barriers, can also cause you to absorb glucocorticoids and cause the symptoms of GWS and also GIAI.
I can take the next. I think it's important to know glucocorticoid withdrawal syndrome and glucocorticoid adrenal insufficiency are somehow similar in symptomatology, but otherwise distinct conditions from many aspects, from etiology, pathophysiology, and more importantly, in diagnosis, treatment, and prevention. We, as clinicians, should be aware of these differences to better treat our patients.
I'll take the last one. So I think healthcare providers should be encouraged to taper glucocorticoids when possible and check for the HPA axis recovery. If patients develop symptoms of GWS when they're while pursuing the taper, then clinicians should consider increasing the glucocorticoid dose slightly to recover these symptoms, and then reattempt to taper down later on when the patient is feeling better.
Great. Thanks again for all of your insights. And I would encourage everybody to read their wonderful article in our Cleveland Clinic Journal of Medicine. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.